the lectures. We go now ahead with next presentation, and please stay in 10 minutes time slot. This is Dr. Shiva Kumar with his presentation, Calcified Vessels Imaging-Based Management Algorithm. But please, 10 minutes, not longer.
Thank you, Dr. Farang. I think Dr. Farang should remember that we had together a case of bifurcation long back at Madurai, Tamil Nadu, and he moved
nice
to
to see you.
Yeah. Right. I see here Sanjeev Rai, fantastic talk, Elilan, Joy, Jabir. And basically, I need to talk on algorithmic approach to calcified vessels. We interventional cardiologists should be applying some algorithms based on thickness, location, and density. And but I thought, let me talk through some of my cases, then finish up with the one algorithm which I thought useful to all of us.
Perfect. But please stay in 10 minutes time.
Sure, absolutely.
Thank you.
Yeah.
Perfect. Okay, go ahead, please.
This is a 17-year-old male with chest pain, angina, inferior LMI, recent mild LV dysfunction. One can appreciate from here there is a critical lesion involving the ostium of the LCX. The LAD looks diffusely diseased. There is one spot lesion which is dubious at the medial AD or distal AD. There is angiographically moderate calcium because you are seeing a calcific tram line on either side of the luminal silhouette, even without dye injection. So this is a conventional preparation with the NC balloon, and just to know, is it crossable, is it dilatable, is it no more Dogman effect? Is it crossable and dilatable, but the balloon is not expanding to a complete satisfaction, but still we thought we can do an imaging now at this point of time. And this is a OCT pullback from LCX to LM, which is now showing a decent outflow with no vulnerable block. MLA is perfect. The block burden is not decent, almost nil block burden. We got a decent landing. Now we can appreciate the calcium, which is concentric, deeply seated, but thickness is not that great. So in thickness aspect, it is perfect, but it is deeply seated and concentric. So as we are reasonably happy with our initial preparation and the luminal gain was okay, we thought we will just for a second move to the LAD by anesthesiology, which showed an RFR of 0.84 and FFR of 0.77. But when we pulled it to just above that spot lesion of the medial distal AD junction, it was looking okay. So we just did a spot stenting to the medial AD. Then this is the medial AD now looking. Then now we were able to drop in a stent from LM to LCX, which is usually generally very rarely being done. However, the LCX is dominant, huge. However, the LAD looks small. People generally take LAD as a first vessel. But here, clearly, we thought the LM's LCX is really huge. There is a big OM. So we thought the lesion was only involving the L6 ostium. There was no great disease in the LAD, which was proven by physiology too. Then this was a stent. Then subsequently, after deploying the stent from LM to LCX, from the perspective of OCT, we did a part of the LM. I think it was the 4.5 or 5 balloon. I don't exactly remember, but we respected all the insights we got from the OCT, and this is how it finally landed. And we did the post-PCI OCT pullback too. And being a LM huge vessel and coming across the LAD, which is not at all pinched, so we thought we will leave it untouched. And this is a final post-stent pullback. You can appreciate the expansion is more than 92%. The MSA is 7.73. When you come closer to the LM, it is 9.96. So here is an basically we adopted a physiology of balloon behavior. It's crossable and dilatable. And with this initial preparation, the OCT clearly showed it is deeply seated calcium, less thick. Luminal grain was great. So we thought we'll proceed with the stent deployment, expansion, and the post-PC optimization by one pullback. This is final look. And I know that the side branch has various options like part, side branch opening, part, case. And cases like this, you can just leave it untouched also. This is another case, diabetic CAD, chest pain, 66-year female. So we know that when CAD has a great chronic stable angina with great medical management is available, elderly population is growing up with the diabetes CKD jumping in. And another group of patients are female, frail, small vessels. When they get an added component of calcium, they are also one group. We get this limitation of calcium causing inadequacy of expansion. So this is a case where the interest of the lesion was LAD. This is a normal RCA. After the decent preparation, there was a wire in the side branch too. This is again an OCT pullback. Basically, the OCT was done to know whatever the initial preparation was. It's okay. Does it need any other additional kind of modification after the initial assessment, after the initial preparation? If you look at carefully here, you can see the predilation induced dissections at the distal part, whereas when you come more closer to the, you can see the calcium. Now, this compared to the last case, here the calcium is really thick, even though it is deep-seated, really thick. Thickness is more than 1,200 microns. I think I did an additional preparation with the scoring balloon too. Then subsequently, the stent was able to track well. There was some pinch of the diagonal for which after the path and dot, we had a cross to that and we did a kissing. Hence, the side branch was not of that great size. We just decided to do it with the balloon treatment alone. Angiographically, the results look great. Again, I want to emphasize the fact that now you see the OCT, post-OCT pullback, the expansion is 100%, the opposition is good. So basically, it tells the pre-PCI stent imaging after the initial preparation. Either you take a call on your balloon behavior, or but with an initial, whatever the preparation you do with an imaging, if you think your preparation is inadequate, you need to modify your strategy by some special balloons like IBL, OPN, or whatever kind of stuff. But before dropping a stent, make sure the preparation is adequate. This is a final angio. I want to finish with another final case. This is again a very multivessel disease, total LCX. After fixing the LCX, we meet to the LAD. Compared to the last case, this case also kind of a female presented with LAD diagonal lesion involving the ostium of the LAD. We wanted to make sure unnecessarily we don't want to protrude the stent into the LM if the LM is looking disease-free. And also we thought with a special technology called as BOOM, bifurcation osteal ossificated mapping, if LM is not involved, it can be exactly land at the ostium of the LAD. After the initial preparation, conventional preparation, the OCT catheter couldn't track. I couldn't get an imaging. So I thought better do one scoring balloon. You can even appreciate in the scoring balloon, in the proximal part of the balloon, the scoring balloon is still not telling us it is adequately expanding. But somehow managed the scoring balloon with the repeated dilation, with a little upsizing. We managed that particular part, which was giving trouble to the OCT catheter, where we were appreciating the balloon, it was showing persistently dark bone. We chased that. Then subsequently, when we got an OCT imaging, now angiographically also the vessel looking decently prepared. And from the OCT pullback too, the luminal gain was excellent. It not only helped us to assess the size, landing, and length, it also helped us from the perspective we learned by the imaging catheter is not tracking, as well as balloon is not expanding fully, which made us to venture on further on preparations, which made now cracks, not only in the non-calcified areas, also in a deeply seated calciums. So when you demonstrate a fractures in two different quadrants, the non-compliant artery becomes more pliable now, so that whatever the stent gets deployed, you can now. This is what I wanted to emphasize. This is so we were made it sure that ostium of the distal shaft of the LM as well as distal LM involving the LCX ostium was totally disease-free. So we precisely, with the technique of OCT with an ACR, we thought we will exactly land at the ostium, which we did today. Again, like a similar last case, we had some impingement on the diagonal. The size was not that great, but we quickly crossed. These are all the learnings I heard from, learned from Dr. Ferenc. He's a bifurcation specialist. He respects all the branches, because God made every branches for some meaning. So we need to respect every branches. So just peak bifurcation kissing was done and got the vessel back. It was flowing. Just one final was to pull back. This is my final slide. You can appreciate clearly this is an OCT guided ACR after the dealing of the in an ACS kind of a situation, after dealing the calcium for adequacy of preparation with an OCT. Now LM was spared of disease. Now clearly this boom technique, bifurcation ostial OCT guided mapping, helped us to exactly land at the ostium of the LAD without overshooting into the LM, without compromising the LCX ostium, without much shift in the carina. Of course, the carinal tip angle was good, and the bifurcation angle was also that great. So just to conclude, this is the algorithm I wanted to just tell. So any lesion, de novo lesion, if the balloon is uncrossable, the option is only rotational atherectomy, orbital atherectomy, or laser atherectomy. If the balloon is crossable but non-dilatable, then this is the point of time once you take the help of imaging. The imaging shows if the calcium is of more than 270 degree and deeply seated shock wave. If it is more than 270 degree, again superficially located, again you have to get into the rotational atherectomy. If it is less than 3 quadrants, nodular calcium, then it is should be rotational or orbital atherectomy. If it is less than 270 degree, you can get away with less than 2 quadrants, you can get away with some balloon based preparation. Once the initial modification is done, we need to assess again, either by the balloon behavior again, now with the NC balloon, 1:1, if it is fully expandable, or you can take a help of imaging again. If you still feel that balloon is still not fully dilatable, or the imaging shows no demonstration of fractures, no good luminal gain, then again, you have to adopt to one of the preparation strategies, then subsequently drop in a stent and finally assess the stent, how it get optimized. These are 3 real world case scenarios. Just I thought I will share a combination of calcium in a diabetic, CKD, elderly, ACS, or 3 different kind of population, how I manage them. Thank you, Varun.
Thank you, Shiva, for an excellent talk. Sir, Ferenc.
Yeah, thank you so much. I think a very nice algorithm for younger doctors. What I would like to ask you, in your daily routine, in how many times do you go with rotablation as a kind of lesion preparation? It's in 1% of all PCI cases, or maybe 5%. Will be interesting for younger doctors.
I think if you ask me frankly, my rota penetration is less than 1%, because I take this inside. If the imaging catheter doesn't cross, if my initial balloon is not crossing, that's the point of time I think of rota, which is a case less than 1%. Most of the time, your lowest profile balloon available in the shelf should do the job. And subsequently, if your balloon is doing some expansion, and if you're imaging now, after the imaging, if you understand the morphology and your location and thickness, I think we can definitely play with whether it is rota or non-rota. At the end of the day, we need to understand the morphology. We need to make sure you are going to expand your stent well. I think in my lab, the penetration is somewhere around 1%.
Yeah, I think interesting information. What we have done in our high volume center in Bad Kreuznach in Germany. So we have now the rate of rotablation is something around 7-8%. So what we have learned, it's easier and better to go primary if we see a lot of calcium, and if we perform imaging and we see there is a lot of calcified segments, so we go primary with ablation using usually rotablation. And now since February we have also orbital atherectomy system, so we have done now around 60 cases. So that's a huge high number of cases in Europe. So we can say this device is really working very nicely and a good alternative also to rotablation. Okay, thank you for your perfect presentation and really fine, perfectly done cases, including imaging. So I think this is